Hi, Lucy. Thanks for
Hi.
agreeing to chat to me today on the request of maternal OCD, because you've very helpfully agreed to answer some questions about what it's like to go to mother baby unit
Yeah.
when you have OCD. Because I suppose some women with OCD were wondering what it's actually like to be
hmm
admitted to an MBU when you have severe OCD. There's a bit of mystery around that.
Yep.
Um, so we should start by saying who we are. So I'm Alexa Roxborough. I'm a clinical psychologist at the Centre for Anxiety Disorders and Trauma. I'm the clinical lead of the Parental Anxiety subservice, which is where you used to work, which is how we know each other.
Yep.
Um, but your first love is for working in mother and baby units.
Yep.
So you've returned to Slam Mother and Baby Unit where you've been very happy ever since. Is that
Yep.
right?
That's true. Yeah. So my name's Lucy Butler. I'm a clinical psychologist as well. I had a placement here actually when I was training a long time ago now, and then I worked at the Homerton MBU for a bit, and then I worked with you at PACS, and then came back here a few years ago now. So now I work on the Bethlem Mother and Baby Unit in South London.
Yeah, and I think you're the perfect person to talk to about this because at PACS, it's like an outpatient service, so I'll often see people, well, actually not that often, sometimes see people who've been to an MBU or people who need to go into an MBU. So I hear about MBUs, but I've never been into an MBU myself. So I'm going to put the questions to you that maternal OCD are kind of wanting to know a bit more about.
Mhm.
Um, so say you're someone with OCD, severe OCD, you need you really need help support in the postnatal period. You're being admitted to an MBU.
Mhm.
What happens at admission? Like, can you talk us through step by step what it's like to like go into an MBU?
Yeah, sure. So, um, well, I think it's obviously we know it's really daunting for people to come into an MBU. It's a big thing. Often people may never have had an inpatient admission before to a mental health unit, so it seems really scary. But it's all talked through first of all. So whoever they're working with, whoever refers them, should have a long discussion with us on the unit first to refer, to go through the criteria, to talk about everything. And once an admission is arranged, often the manager or one of the leading nurses for the day will contact the client and talk through themselves what happens. So basically, they'd arrange the time for mum to come in. Some mums come with their baby straight away. Some mums they come by themselves initially, and then their baby may come and join them in a day or two once they're settled. So when you get to the unit, you'll be welcomed by a nurse, and you'd have an admission kind of clerking period. So that would be talking to a nurse and a doctor, having an assessment with them, talking through kind of everything that's been going on that's been led up to the admission. You'd have a tour of the ward and be shown your room, opportunity to ask any questions and everything like that, shown the nursery, shown where family can come and see you. Often people will have a family member with them as well when they first come in. And you'll often, well, you'll hopefully have already been given a welcome pack as well. So that's kind of a big pack which gives you all the information that you can look through at your leisure, but then that would also be given to you when you come in. So it's really thorough as an assessment, and we want to kind of make people feel comfortable. Obviously, it's an inpatient setting, so it can be a bit busy sometimes. It can be a bit unpredictable, but I've worked in adult inpatient wards, and this is a lovely ward compared to general adult inpatient wards. So it's really a positive place, and there's often varying kind of cases here. So it's a really vibrant environment, but it can be quite therapeutic as well. And lots of staff have worked here for a long time, so we hope it can be as supportive as possible.
It's really helpful. So you said it can be quite busy, but each patient has her own room. Is that right?
Yeah, so we have 12 beds here, so we've got space for 12 mums and I think technically 13 babies because we've got one room that can be for twins. And every mum has their own room. Unfortunately, there's no ensuite rooms here at the Bethlem. Some MBUs are newer and have ensuite rooms, which is obviously more desirable, but location is so key. I think being close to family is really, really important. So there's a big push now for mums to be admitted to their closest MBU. And if there isn't a bed available at your closest MBU, you will go to a different MBU, be offered a bed somewhere else, and then as soon as there is a place at the local MBU, you will be offered the chance to move there, because we know it's so important to be nearer to family, to be near as possible to family. So I guess that's where the ensuite is cancelled out in terms of it's so important if this is closer to your home, closer to your team, closer to your usual area. So every mum has their own room. There's also a lovely kind of nursery like lounge area. So that's where mums spend most of the time hanging out. And that's a really big space, really bright. There's a milk kitchen where you make your bottles and things like that if you're bottle feeding. There's a whole changing room with changing stations and baby baths. There's a sleep room, which is a baby sleep room. So some babies sleep in there, and that's like a dark like room with temperature control, and it's got like a window so that staff can see through and everything, and cots in there. And then there's like a washing room for laundry and things like that. And there's a big garden that comes off the nursery space as well. Unfortunately, we don't actually have a video tour of our MBU online, which is something that's trying to be sorted out, but other MBUs do have video tours. And also, if you live kind of close enough and you're coming into hospital, you're planning or considering an MBU admission, you can come and visit and have a tour before being admitted. So if you want to come and see what it's like and think about it, you can do that too. And somebody, often the manager or one of the senior nurses or one of the psychologists, can show you around.
Right.
Yeah, so it's quite it's quite flexible in that sense. And there's different rooms as well. So it's like a conference room for meetings, dining area for meals. There's a kind of patient kitchen where you can cook and make meals and do OT stuff. And then there's a couple of different therapy rooms as well. Oh, and a sensory room, which is kind of new, which is lovely. It's like got all sensory equipment and like soft flooring and things like that, where you can go with your baby. Staff can take mums in there to kind of have sensory sessions as well.
Sounds like a really nice environment. Obviously the lack of en-suites is a bit of a downside, but it's balanced out by being close to your family if you are from the area. How often are family allowed to come and visit?
So family can visit every day. There is a kind of limit on how many family can visit at once, because obviously it can get quite a lot if everyone's having lots of family visit all the time, because you might be in communal spaces. But most people, I would say, have visitors pretty frequently. You can have visitors come every day, and you can spend time with them in your room or in the nursery, or if you have leave or you're informal, you can go out and spend time. We have beautiful grounds here, so that's another really positive part of the Bethlem. And there's a visitors room, and there's also the big conference meeting room. If it you're well and you can see your family by yourself in there, then you can use that room as well as another space, or you can obviously hang out in a nursery, but there's often other patients and families there as well. So it's trying to work out where the best space is for you. But yeah, family can visit every day. There's just protected meal times between 12 and 1 and 5 and 6. And the latest people can visit is until 8 p.m. So yeah, we try and kind of visitors leave by 8 p.m. so that they can be the kind of wind down baby routine. Like they do like a sensory kind of calm down session in the evening in the nursery, so mums can settle their babies to sleep.
That sounds really nice. So babies sleep in the nursery. What if I have OCD? I'm very anxious and I want my baby to sleep in my room with me. How is that sort of handled?
So it's really handled on like a case-by-case basis. So on our ward, it's different across all MBUs. So I can't say what it would be like on another MBU for sure. And again, this is something that you could speak to the MBU about and chat about before admission. But on our ward, we have like a traffic light system of red, amber and green. So red means that you care for your baby in the nursery in the day, and staff are around all the time to offer you support. And that also means that your baby sleeps in the nursery at night. And if you're breastfeeding, say, staff will come and get you, or if you want to do the feed, staff will come and get you and you come to the nursery to do the feed, or staff will feed your baby in the night and you can sleep. Amber is the same as red in the sense of the baby sleeps in the nursery at night, but you can move around the ward freely with your baby in the day. You can have your baby in your room, you can move around the ward, you can go to different areas, take your baby to the dining room or be in different spaces. So that's kind of lower down on the risk level. And then green is where your baby sleeps in your room overnight. And obviously some mums want to be on green straight away and don't feel comfortable with their baby being away from them. It's really balanced on a case-by-case basis. So we know in OCD that if mums are having, say, thoughts of harm to baby and they're intrusive thoughts that are really distressing, we know that the risk of them actually doing something like that is very, very is low, is minimal, 0. But on admission, because we don't know mums yet, we need to understand their challenges, we need to formulate and assess. it can take a little bit of time. So it's just about trying to understand mums as soon as possible, work with their wishes, because what we don't want is for mums to feel more distressed or more anxious coming into hospital. Obviously, there's a transition period where you might feel a bit more anxious initially until you settle in, but we want mums to feel empowered, and it's about how we share the message with staff and make sure everyone understands that this is not a risky person, this is not a risky case or anything like that, and that actually separating mum and baby at night might be detrimental. So it's definitely done on a case-by-case basis. And if mums want to work towards green, we do that as soon as possible. Some mums want to be on amber, actually, because they recognise that they need sleep, and that can be really key, because if you're somebody who's very, very sleep deprived in the, say, postnatal period, you might actually really need some sleep to help you get better, to help you recover. So it's really a balance. And we want to also mirror what happens at home. So say at home you share the care with your partner at night, you have a partner around. We want to mirror that here. And the transition from amber to green can be managed in a way that's helpful. Yeah, so it's very much a case-by-case basis, but we want mums to feel empowered with that decision making as well.
That's great. So if I could just summarize, because it sounds like, I guess, amber or red could sound scary, just if you don't know what that really means, but actually it's just like the level of support. So actually, you know, it's just higher levels of help to care for baby. And, you know, for any mum who has OCD around thoughts of harm, you know, you are a clinical psychologist, so in MBU it's a multidisciplinary team, so there's nurses, there's psychiatrists, so when, as you said, meeting a new patient, it's kind of the assessment process. Psychologists are there, you know, to help understand, help everyone else, help everyone around the person understand this is OCD. So if these are intrusive thoughts, you know, in an OCD picture, then that can be quite clearly kind of communicated to other staff, and then the traffic light system will reflect that once the person's been kind of fully assessed and said. Is that an accurate summary?
Yeah, definitely. And I think it's that sense as well of, we understand that, you know, these are new people on the ward. Like, there's always nursery nurses on the ward, so the nursery is staffed mostly by nursery nurses and also kind of support workers as well. But we know they're new to you. You don't know them. They could be anyone, can they? So it's a sense of we want people to build up trust with the staff, and as that starts to grow, they feel more confident leaving their baby there, because you might at other times in the day leave your baby in the nursery, say if you come to a psychology session that's more individual work with you, or if you have some other type of meeting where you're board round. And we want to give mums also time for themselves. Like, you want to have a bit of time for yourself, and that might actually be a goal for you if you've been very consumed by anxiety around leaving your baby at all. So I think it's, really thought about very carefully. And, you know, our nursery nurses here are so experienced, lovely ladies who've worked here for a long, long time. So it's, you know, very multidisciplinary space in terms of the support that's available.
Okay, so that's helpful, thinking about, you know, OCD around intrusive thoughts, thinking about other types of OCD. Say, for example, if I have contamination OCD and I'm coming onto a ward and I'm very scared about coming into an environment that I feel might not be clean enough or might have germs, you know, can you say a bit about how that might be sort of handled if that's my main obsessional fear?
Yeah, definitely. So again, I think recognizing this as a case-by-case basis and what's like possible. So obviously people have their own rooms and they can keep their own rooms however they want to keep their own rooms, but there are certain things that need to happen. So like, rooms need to be cleaned by our cleaner each day and things like that, but you can work with the staff and with the cleaner to kind of do that in a way that feels safest for you. It is like a kind of ward approach in the sense of, you know, we want to help people challenge their OCD, I guess, from the beginning, because we know even coming into a ward can be very challenging. So you're already doing the treatment, aren't you? But that sense of, you know, people can't be, I guess, doing loads and loads of extra cleaning of communal areas, because that could interfere with other people's care and things as well. So it's how to help them feel like spaces are clean enough and how to set some limits. So say, for example, if somebody was doing like really long washing routine, that may need to be capped in some way, and how we can help people do that from the beginning, because if there are shared bathrooms as well, you need to move on from that space. You might need not, you can't stay in there for as long as maybe you would like to at home. So it's all about kind of recognising that's part of the treatment and supporting mums to make those changes. But I think it's one of the things that can be really helpful, because in a way stepping into this space can help you make those changes happen straight away, because it has to be different, doesn't it, to how it is at home. Yeah, and we want to, you know, help people take those steps in a way that feels supported, so staff understand what OCD is, and there'll be lots of thinking about, you know, what happens when I'm triggered, how to help me, how to coach me through this, rather than just feeling challenged all the time, which we know can be stressful.
Okay, that's really helpful, because it sounds similar, you know, when I work with someone in an outpatient way and we're doing exposure, it's you know, it's kind of negotiated with the person's consent, like what can they tolerate, you know.
Yeah.
You're not trying to take someone outside their window of tolerance.
No, exactly.
Not trying to do things to people against their will. So it sounds like it's very similar and then in the MBU as well.
Exactly, yeah. So we want to do that in a way that's paced, and you know, people might be having certain goals, and if one day it's too tricky, it's like, okay, we just slow it down. We share that with the team, and there's definitely a lot of thinking with the team together. When somebody is actively tackling their OCD all the time, that's very exhausting for them. So how to support them through that, and how to help staff feel empowered, because some staff obviously may not know loads about OCD, like obviously the psychologists do and the medics, but sometimes we might have new members of staff or bank staff, which means staff kind of filling in shifts. So we want to make sure that that's handed over, and there's handovers daily where the staffing team are updated about what's going on for each patient.
Is that the same as, because I often hear you refer to ward rounds, and I'm never sure exactly what that means. Is that just a handover, or is that a different thing?
So that's a different thing. So once a week, so we have six. So we have 2 consultants. So each consultant is allocated 6 patients. So we have ward rounds on a Tuesday here and on a Thursday. So on a Tuesday, there's 6 meetings. So each patient on a Tuesday has a meeting, and that's where you'd come to the conference room. Your doctor's there, there's a nurse, there's a nursery nurse, whoever your psychologist is. If you're working with the OT, they're there too. And then your team can attend online. So say somebody from PACS or somebody from your perinatal team in the community or your other mental health team, they can attend online. And there's like a discussion with you about your care, about your plan for the week, about how it's going, anything you need. Leave is discussed, medication, everything is kind of planned weekly, and then that plan is summarised and sent round, and then that's the action for the week. And then that happens every week until they start working towards discharge.
Yeah, that reminded me actually of someone I worked with who I'd worked with previously, and then she went into the MBU, and because I had that strong relationship with her, I spoke to the psychologist on the MBU. I think you were on mat leave, so it was a different psychologist, and we just agreed that I would continue having a few online sessions with her, and I really liked how that was kind of handled, and I was really kind of brought into the team, and you know, it was a very collaborative approach. So it's not like the person is being cut off from the world and everyone else they have already
no, we really we really encourage people to continue connecting with their treating team. It may be like that maybe their psychology or their input is paused for a bit, but we'd always have like a handover meeting to understand what they've done already in the community, and then when they leave, when we make referrals to onward kind of psychology, if that's happening, we would have another handover meeting, and the patient could be part of that as well. They can join that meeting to kind of hand over what they've done. We've even done those in person, actually, if it's possible, because I think that's a really nice thing to do. But yeah, definitely lots of liaison with services going forward and wanting that pathway to be really clear.
And you do have a social worker in your team, which I know can sort of scare mums a bit.
Yeah, we do. And it's actually a great thing. We didn't for a little while, but we do again now. And so our social worker doesn't work for any local authority. She works for SLAM, she works for the NHS. So she is kind of responsible here on the ward for making links with external social workers. So if somebody is under social services already, or if there's been a referral as part of the admission, or whatever's happened before, she would liaise with the social workers in the community. So if someone's having like a child and family assessment, she would liaise with them and like be there for that assessment if the patient wanted them to be. She would, if there were any child in need meetings or any other meetings, she would go along and help and answer questions about that whole process. So she's a really helpful person to have, actually, because there's actually such a big role, I think, in demystifying social services, because there's so much support they can offer. Obviously, people always worry that it's a scary thing, but actually early help, and there's so much available there for clients once they leave. So I think that's really, really important as well.
Again, like, what if I have intrusive thoughts of harm and I'm worried that there's going to be this sort of automatic referral made to social services? Can you say a bit more about that?
So I think, unfortunately, we know that sometimes referrals are made often pre coming into the ward. Say if somebody's taken something out of context and it's been not misunderstood, it's not really understood that it's a part of OCD, there may be a referral made, and then that triggers some sort of assessment. But I think that's where our social workers and us as a team will work really closely with social workers who are maybe assessing a family to explain, this is OCD, this isn't risk, this is intrusive thoughts and distressing thoughts, and this is how we're treating it. And I think often that can help social workers understand, okay, this is very different, this is not risk related, this is about managing someone's anxiety and distress, and therefore risk is low. So we have that really clear, open communication.
Yeah, because I think it's important not to sort of sugarcoat this aspect, because both of us have seen, that this does happen when OCD is misunderstood.
Yeah.
But equally, like, as soon as the assessment happens, it's always, it's an open and shut case. Like, as soon as professionals realize, okay, this is an OCD picture, it doesn't go any further. Like, at least in my clinical experience, I've never seen anything further arise from that once the picture has been understood correctly.
That's it. If there was any ongoing necessity for a social, it wouldn't be related to the OCD, it would be other things going on, like other stresses in the community or anything like that. So it wouldn't be related to the OCD, we hope.
Yeah, exactly. So we've been focusing on OCD because this video is about OCD, but can you say a bit about the population of the MBU in general? Like, why do people come to the MBUs?
So generally people come to the MBU, they've got a severe mental illness, and that can be OCD, but often we treat severe postnatal depression, severe postnatal anxiety, postpartum psychosis. And I'd say most people come to the ward informally, which means they're choosing to come and be treated here. Some people come under a section of the Mental Health Act, which means they have been assessed as not having capacity to consent to admission. So they have a Mental Health Act assessment, and then they're brought to the MBU under section, or they're maybe transferred from another ward to the MBU to be reunited with their baby. So that's, I'd say, less people come under section, more people come informally, where you're choosing to come into hospital.
So in terms of OCD, specifically for OCD, it would be quite rare to come under section, wouldn't it?
Very rare, yeah, very rare. I think, that's not often something that happens. I think with OCD, people, we see that people have often been really, really trying to manage in the community, and things just, it can maybe be very difficult for people to access treatment, to actually get to appointments and things like that. So I think it's something about maybe making that choice to come into hospital, to have the wraparound care, to have really intensive support that would be more than you can get in the community. So if you come into hospital with OCD on the MBU, you can have therapy more than once a week, and the whole team are kind of treating you from that same approach. So it's progress can be quicker, I think, as well. And also it's providing you with that safety net for you and your baby in that space for them to be cared for while you have your treatment.
And speaking of the treatment offer, can you say what a sort of day on the MBU is like in terms of activities? Obviously you've mentioned therapy, like with someone like yourself, like a psychologist, but are there other things as well?
Yeah, so there's we have 2 OTs, and they run a really great program of kind of groups and different activities on the ward. So there's
OT being occupational therapist?
OTs being occupational therapists. So they offer lots of kind of different groups. There's like a gardening group, there's a maternal journal group, there's some exercise groups, there's like an art group, pampering group, all different groups. So there should be a couple of things on each day that you can attend. They also do kind of individual occupational therapy assessments with people. So say their functioning's been really impaired in some way by whatever's going on for them, it's like that sense of how to get them back functioning again in the way they want to be. So they can do cooking practice, cookery sessions, things like that can be really helpful for people with OCD who maybe really stopped doing anything like that because of the severity of their OCD. Going out and about in the community again, like getting to groups, getting confident with public transport, things like that. And there's an OT department on the Bethlem site as well, and they do loads of groups and things there. You can be referred. There's like boxercise and art groups, pottery, So you'll have a meeting with an OT quite soon after admission, and they come up with like a personalised programme for you. So yeah, I'd say each day, you know, most people have an activity, an OT activity at some point. You might have your therapy session. We have individual psychology and parent infant psychology sessions available here. So you might have like 2 or 3 psychology sessions a week. So it can be quite intense, but obviously speeds up your progress as well. Visits from family, obviously. We're in beautiful grounds here, so if you have leave, you can go out, you can go for walks, you can go to the local kind of shops and area. And then obviously once people start getting a bit better, they will start having leave. So sometimes people go on leave for, say, the weekend, and then that gets a bit longer. And then eventually we hope that people will have, say, 1 or 2 weeks at home, just at home. They don't come back to the ward, but your bed is still here if you need it. And then as long as that goes well, then you're discharged. So it's a very gradual process. It's not like a general acute ward where the admissions are much shorter. The average length of admission here is 8 weeks, but it can be less and it can be more.
So it's very individual, just depending on what that person needs.
Yeah, very individual.
And one of the questions from Maternal OCD was around readmission rates. Like, say, if you need to be admitted to the MBU with your first baby, is it very likely that you'll need to come in again for your second baby? Again, talking specifically about OCD.
So with OCD, I couldn't remember any cases that I've worked with who've been readmitted with a second baby, or, you know, sometimes people are discharged and then they come back in quite quickly, but that's quite rare. And I don't think that's ever happened with OCD, anyone that I've known since I've worked here. And I asked my colleague who's worked here for a long time, and she said she couldn't think of anybody either. So actually we think for OCD, it's very rare to need a readmission, actually, incredibly rare. It's more common for things like depression or psychosis potentially. So yeah, for OCD, very, very rare readmission rates.
Yeah, because it's quite different sort of mental health problem compared to depression or psychosis. I think once you learn what you need to learn in terms of how to kind of tackle it, even if it does rear its ugly head again with your next baby, you have some tools hopefully from the first time, and you kind of know your enemy and you know what to do to kind of keep it in check, I would say.
Definitely. I think so. I think that's it. If it's something that comes up again, people are prepared in a different way and have those skills already to rely on, and may need top-up treatment, but that could probably be met within the community.
Yeah, service like my service. We'll do a different video to talk about my outpatient. And in terms of medications, that's another fear, I guess, sometimes for some people with OCD, if they don't want to take medication. Is there like a pressure to take medication if you're on the MBU, or how would you describe that?
Again, I think it's really individual. You know, thorough kind of medical assessment is part of the admission. You know, you'll have your psychiatrist who will assess you and who will get to understand your needs and think about treatment options. But there are definitely people who are here on the MBU who do not take any medication and don't want to, and that is honoured. Like, that is part of, okay, that's fine. You have, and psychological treatment is their kind of main treatment. And I can think of cases where that happened more often actually with OCD, because people are concerned about that. But also, you know, these are perinatal psychiatrists, very experienced. They know all there is to know about, you know, medication, breastfeeding, what's right for you, what's okay for your baby, all those sorts of things. So people do take medication sometimes, partly for kind of treating their OCD, but also treating, say, anxiety and depression, which may be alongside that. So yeah, again, very individual case by case basis, but absolutely you will not be forced to take medication that you don't want to take. If you're on section, medication could potentially be really encouraged, and then there's that sense of if you are deemed to lack capacity, but I think that's very, very rare for OCD as well.
Yeah, I'm extremely
I don't think that's really relevant, to be honest. In this case,
so it's really because these are specialist perinatal psychiatrists, as you say. They know everything that there is to know about the interaction with breastfeeding. You know, any kind of like fears you have around medication, they can discuss them in detail. They can give you the relevant information, statistics, and then you can make your own decision based on that. Or you can maybe even get a prescription but not necessarily take it if you don't want to, but it's all up to you, kind of thing.
And there's a pharmacist as well attached to the ward who will come and like do sessions with patients and talk to them about medication and things like that. So it's very thorough, and we really want, you know, this to be collaborative. Like, that's how people get better the quickest, I think, if you agree with your treatment and you're doing it together.
That's great. I mean, I've just looked at my list of questions that I think we've covered all of them. Is there anything that I haven't asked that you think I should have asked, like people might need to know about coming to the MBU?
No, I don't think so. I think that's covered just about everything, I suppose. And I guess if people have questions after they see this video, they can contact, if there's anything else we've missed, they can contact Maternal OCD and ask for questions to be passed on. Yeah, but it's also that sense of if you're considering coming to an MBU, please kind of ask to call the MBU that you might be going to and talk to somebody about it, and they'll be very happy to answer questions.
Okay, let me just ask you one last thing then, because I know from working with you before, because you come from an MBU and you're keen to get back, and this is kind of where you really want to be. Like this is like the right environment for you. So what do you really like about working on an MBU?
I really like the variety of work here. So obviously I do work with OCD, but I work with lots of different cases, lots of different types of presentations. And what I really love is seeing mums, you see mums get better. It's really, really positive place to work. It's a lovely place to work. Mums here with their babies. We're keeping people together as families. So I think it's that sense of recognising that we know treatment alongside your baby is so helpful, and we can offer that, and it can be really quick compared to, I think, say, kind of a long protracted piece of work in the community that might be very effective but can take longer. And we want people to get better as quickly as possible when they have a young baby. So yeah, it's a very positive place to work as well.
That is lovely. Thank you so much, Lucy. Appreciate you taking the time.
No worries. Nice to see you.